we have Professor Nicole Concin from Austria, the head of the European Society of Gynecologic Oncology. She is going to give us her talk about quality indicators in endometrial cancer surgery.
Thank you very much again, and I just can emphasize that it's really an honor and a pleasure to be here. I enjoy so much. Thank you so much for inviting me. And I was particularly happy to hear we have now 2 ESCO accredited centers in Egypt already, and we're very proud about this. And obviously more centers are interested. I learned today about the oldest and biggest, and it would really be our honor to connect you with the ESCO, and I hope you will apply soon. I will certainly support the process and speed up the process and help whenever I can. So this is about quality indicators in endometrial cancer. We have, my disclosures, we have ESCO accreditation for training. We have ESCO accreditation for ovarian cancer surgery, and we have accreditation now for endometrial cancer surgery. This is the 3rd one that we just implemented, and all our accreditation processes are based on our ESCO quality indicators in surgery. So this was a product that we developed in 21, the quality indicators in endometrial cancer surgery, and on them the accreditations are based, and we have just launched them in September last year, so this is a brand new accreditation. For ovarian cancer we have already 70 centers in Europe and beyond accredited. For endometrial it just started. We had the first center in France accredited, and I heard for example, your big center with 150 cases. I mean, a minimum requirement is 50 cases per year for endometrial cancer. So how does these accreditations work? We score the quality indicators. So all the quality indicators come with a number, with a score, if you reach them. And for accreditation, you need to be above the cutoff of 80% of the maximum score. So you don't need to fulfill each and every quality indicator. They all come with a score, but the overall score, if you sum it up, has to be above 80% of the total score. And then we have regular accreditation and excellence, centers of excellence, and they have obviously more strict criteria. So for endometrial cancer, it's 29 quality indicators. It's impossible to go through all of them now, but I will stress particularly the general and the intraoperative quality indicators. In endometrial cancer, the same as in ovarian cancer, numbers matter. This has been nicely shown in the literature over and over again. Survival depends on the volume of the center, depends on the caseload, and this is true for all histological subtypes. So as we said, the number of new diagnoses for ESCO accreditation is a minimum of 50, minimum required targets. Sometimes we have minimum and optimal targets defined, and the optimal target is above 90 cases. The number of surgeries in endometrial cancer, again, minimal required target 50, optimal target 80. Not only the numbers matter, also who does the surgery matters a lot. There is literature that shows that if you're treated by the gynae-oncology, this is an independent prognostic factor for improved survival. In our quality indicators, we state that the surgery should be done by a gynae-oncology or a surgeon who is specifically dedicated to gynae cancer. So you don't need the subspecialty, you just need to be dedicated to the disease and do this all the time. Then it doesn't matter. A lot of also European countries don't have subspecialty in gynae-oncology still. So the surgery should be done or supervised. In our quality indicator, we also allow the supervision by a trained surgeon or a gynae-oncologist should be more than 95 cases. Multidisciplinary team discussion of patients is of course very important. Here we also define, you see particularly in the relapsed case, all patients should be discussed in multidisciplinary teams. Andreas Dubras has nicely shown for ovarian cancer that centers that participate in prospective clinical trials have a better survival than patients who are treated in centers that don't. Of course, centers that participate in trial, they have a good infrastructure. A lot of high quality is needed by trial participation. You have to reach, you have to improve your quality. So obviously this affects survival of the patients. You're at the pulse of time in the treatment, and this is also a quality indicator in endometrial cancer. The minimum required target is that you have an ongoing prospective study in gynae cancer, in any gynae malignancy, and the optimal target is that you even have trials running in endometrial cancer. I will focus now on the quality indicators. Intraoperatively, I said the preoperative follow-up, I cannot go through all in 20 minutes. So these are the guidelines that we have recently published in endometrial cancer, and I want to stress what you see here. What is important is that the minimal invasive approach is now clearly the preferred treatment approach in early stage disease, in stage 1, stage 2. Intraoperative tumor spilling, it's very important to avoid it. And this has all been implemented in the quality indicators. So rupture of the uterus needs to be avoided in early stage disease that is treated minimally invasive. Target almost all patients is of course the target. Successful minimal invasive surgery. What means successful? Successful means without intraoperative peritoneal spilling, without rupture of the uterus, of course without morcellation and without conversion. The minimum required target in early stage disease is 60%, the optimal target 80%. We know from the literature that the minimal invasive approach is particularly beneficial in the obese patients, and so we have defined this quality indicator, the portion of patients that are obese, BMI above 35, successfully treated with minimal invasive surgery should be more than 60%. Conversion rates from laparoscopy to laparotomy, if it's done in experienced hands, in excellent center, in high volume centers, the rates are in general below 10%, and this is our quality indicator. We aim for a conversion rate of less than 10% in ESCO accredited centers. Intraoperative injuries, nice Cochrane review. You see mainly the overall intraoperative injuries, bladder, urethral, vascular, bowel, should be below 2%. This has been implemented as quality indicator. Infracolicomantectomy, when does it make sense? According to our guidelines, it makes sense in serous histological subtype carcinosarcoma and in undifferentiated. In clear cell, you don't need to do it. The rate of microscopic disease is very low of the omentum, but in the mentioned subtypes, it should be done, and it should be done in these subtypes in more than 90% in ESCO accredited centers. One major advancement in our endometrial carcinoma guidelines is the Sentinel lymph node concept. This really changed now in the updated guidelines. It is now accepted as alternative to systematic lymphadenectomy. So Sentinel lymph node is an alternative for staging of the lymph nodes, and if this is properly done, no systematic lymphadenectomy needs to be done. We state in our guidelines that the Sentinel lymph node concept can be considered in low and intermediate risk patients. These are patients where no systematic lymphadenectomy should be done. So you can consider doing a sentinel lymph node. A lot of the big centers in Europe do it also in low risk disease, because at the end of the day you only know if your patient is really true low risk after you have evaluated that their lymph nodes are negative. And also in low risk patients you find in about 5-6% you find metastasis, so they become automatically stage 3. So this and in the intermediate risk and high risk patients, of course you should do lymph node staging, and then in experienced hands, in well-trained surgeons, it is an alternative to systematic lymphadenectomy also in the high-risk cases. And there are now 4 prospective cohort studies in high-risk cases that have shown that this is safe to do. So we state that in high, intermediate and high-risk cases, lymph node staging anyway should be done, and the proportion of lymph node staging in these patients should be more than 85% in ESCO accredited centers. And this is a very important quality indicator, because we really want to promote sentinel lymph node, and this is to promote it. The proportion of lymph node staging done via the sentinel technique, the target is more than 90%. So this is a strong message to replace systematic lymphadenectomy by the sentinel lymph node concept. And this is, for example, a requirement for the excellence center. So they have stricter requirements. Then the numbers, we already said numbers matter. So per surgeon, the sentinel lymph node technique should be applied per year in more than 20 cases. Also here, a message: implement sentinel lymph node technique responsively, train the surgeon, experience, volume matters. So it should be done always by the same people to have the experience. Which tracer to use? There are randomized phase 3 trials on this, and they all clearly show that indocyanine green is the best tracer to do the sentinel lymph node technique. It has the highest mapping rate, it has a rapid uptake, it has the advantage that you can re-inject the tracer. If you don't see the sentinel up front immediately, you can re-inject, you don't need to wait for a long time, and this displays actually lymph vessel, and they guide you to your lymph node in contrast to radionuclide tracers. So the proportion of indocyanine green used as tracer to detect your sentinel should be above 95%. This is also a very strong message, and this is a mandatory quality indicator for the excellence centers. And then if one side does not map even after re-injection, then in the intermediate, high and high risk cases you have to do lymph node staging, so you need to do a systematic lymphadenectomy, site specific, and this should be done in more than 90% of cases. Importantly, sentinel lymph node technique should always be accompanied by ultra staging. It makes no sense to do sentinel without ultra staging, because through the ultra staging you will find small volume disease, micrometastasis and isolated tumor cells, and it has been shown that this is the case in about more than 30% of your patients. You will miss this small volume disease if you don't do ultra staging. So this led to these quality indicators. The proportion of patients that underwent ultra-staging, if sentinel lymph node technique is applied, should be in ESCO accredited center. We aim that this should be actually in all our patients. And then the bilateral mapping rate of sentinel lymph node is, of course, a quality indicator. We know that your bilateral mapping rate increases with experience, with volume, and it should be more than 75%. If you look at the trials being done in the excellent centers, Jan Persson, 95% bilateral mapping rate in the SHREK trial. So you can tell these are experienced hands, and this is our quality indicator. Very, very important, the advanced stage disease, stage 3, stage 4. We do know that as in ovarian cancer, complete macroscopic resection in these patients is of benefit for survival. So this is the approach. In our guidelines. We state that complete macroscopic resection, if this can be achieved, or it seems preoperatively you can achieve it, then you should go for cytoreduction in these patients if the morbidity is feasible. And the aimed rate of complete resection, if you go for surgery in these advanced stage patients, is more than 75. If you compare this to ovarian cancer quality indicators of ESCO, advanced stage disease, macroscopic complete resection rate, our goal there is more than 65%. So here this seems high, 75%, but you need to consider that this includes stage 3 endometrial cancer, which is no peritoneal disease. This is sole lymph node disease. So this is why, of course, we here aimed for a higher rate. The relapsed situation, if the patient relapses and you consider salvage surgery because the patient had radiotherapy before and the only curative attempt is again surgery, you should be very strict with your indication. This only makes sense in patients where complete macroscopic resection can be achieved. We talk about accentrative procedures. It needs to be stressed that this should be done really in very experienced centers. Centralization is extremely important, and these patients do surgery only when you're really sure you can do it, or refer it to centers that can do it, that have the experience, and when you expect the complete macroscopic resection. So this is why this target is extremely high, with 95% for ESCO accreditation. I did not include these due of the time. Molecular classification is now game changer in endometrial cancer. This is a molecular disease. This leads to personalized treatment in our patients, to improvement in our patients. And we have also quality indicators here that target this, and also quality indicators that I will not elaborate now in detail about what should be in the surgical report, what information, what should be in a pathological report, what's about morbidity, mortality conferences, all these things. But I focused on the operative in this talk. Yes, and this is what I'm going to expect tomorrow when I'm back in Austria, a lot of snow. Thank you very much.
Thank you very much for your comprehensive talk. And I think many Egyptian centers will join you, because we have at least 4 centers, the National Cancer Institute and South Egypt Cancer Institute and Nasser Cancer Institute. We do in the National Cancer Institute at least 700 cases of gynecologic malignancy, including about 250 uterus, 250 ovarian.
We will have a lot of excellent centers in Egypt in the future. I'm looking forward to. This is such a wonderful, it was last year a starting point for me. This great cooperation with Egypt. Unfortunately, online, and it's so fantastic to be here now and to hear all this. And I really hope we can strengthen our cooperation and have this accreditation and do educational events together. And certainly, our ESCO Representatives Council, we are happy to come and visit and support whenever we can.
Thank you. Any question?
Yeah.
Any indicators about the role of para-aortic or lymphadenectomies? When you say systemic, you mean both pelvic and para-aortic? And in which patients para-aortic, which morbid patients is omitting the para-aortic is really, accepted? Because one of the big papers, if you look at it, and it says comprehensive, I don't want to name the centers, but comprehensive surgical staging for the morbidly obese patients and all this, and you find that they've done para-aortic lymphadenectomy in only 50% of cases. And the rest is only pelvic, and the reasons for omission: morbidity, thromboprophylaxis, DVT problems, patient on anticoagulant before surgery, increasing time for the initial surgery, so anesthetic concerns and all this. And that's what we face in reality. So have you mentioned this?
Of course, this question is the crucial question, and a lot of controversy about this. And there was so much controversy on this when we developed the guidelines. So the first step was the guidelines, and the next step was the quality indicators based on the guidelines. So what we say in our guidelines, because this is controversial, and I think there is no clear evidence that we can say you have to do this and everything else is wrong. So what we said is, first do the Sentinel, and you see our concept allows to do it in all patients. If you don't do the Sentinel, do the systematic lymphadenectomy in the high, intermediate, and in the high-risk patient. And ESCO says, if you do systematic, then do systematic pelvic and para-aortic. This is what we say. But we didn't specify, for example, what happens intraoperatively. Some do still even send, or you see a suspicious lymph node, or you palpate in the pelvis. They send it to fresh frozen. It's positive. Some stop, yes. Others would do full. Others would stop, then do imaging, PET for para-aortic, then determine the radiation field. I personally don't think that our patients die due to isolated para-aortic relapse. I don't think this is the reason why the patient dies. Yeah.
Thank you, Dr. Nicole. Any other question? Okay.
Thank you.
Thank you very